My name is Joe Cummings. I am the Reno Market Director for DispatchHealth. And I'm going to go ahead and share my screen here, and I'll introduce my co-presenters. With me presenting today is Kevin Riddleberger. He is a Chief Strategy Officer for DispatchHealth and the co-founder. Kevin, say hi, make sure you're off mute.
Hey everyone, thanks for having me.
Fantastic, so glad you could be here today. And Tori Brizzi, who you've met if you were networking with us early, like you should be. Tori is one of our business development managers. Tori is based in Las Vegas, and she and I work together to cover business development for Reno as well as Las Vegas where we can. While Kevin and I are busy telling you more about Dispatch, Tori is going to be monitoring the chat. And so if you have questions, make sure you put them in the chat, please. Tori will either just answer your question or she'll save them up for the end, and then we'll go from there. So I wanted to just give you a little bit of background here. Renown Health brought DispatchHealth here to Northern Nevada back in April, May of this year. And since that time, in that few 8 months or so that we have been in business here in Reno, we have seen over 2,000 patients. So I'm just curious, just out of show of hands, if you can use your little show of hands tool on your Zoom there. Have any of you already been patients of DispatchHealth?
I saw a few hands. Yes, I did.
Right. Terrific, terrific. Well, for those of you who have, or whether you have or you haven't, we have some really cool new stuff to share with you about not only what we're doing here in Northern Nevada, but some of the things we have planned. And I think you'll be really amazed at all of the technology and everything that Kevin has to share. So with that, I will turn it over to Kevin for the next few slides to get us started.
Just to set a little bit, further context, we're going to go over the service itself to give you a basic understanding the type of clinical care that we're delivering in the home, there in the Reno market, but also all across the country. And I'll spend a little time in terms of the creation story, how we got started and where we're at today and where things are headed. Then we'll dig into more of the technology pieces that are actually powering this thing. Without a basic understanding of the clinical services, it's tough to really identify how the technology pieces really work. And so I think it will allow you to understand it a little bit further. So I'm located in Denver, Colorado right now, and that's where our headquarters are. That's where we were born and raised. Myself and my other co-founder have been practicing clinicians for many, many years, seeing patients. And through those years of seeing patients, we really understood the challenges that patients go through in accessing care, understanding the right size of care that's needed for my or their acute medical problem, and then being able to deliver that care effectively, as clinicians. And that's where some of the technology, comes into play. Something I often talk about is, as a clinician, you're really boxed in as to what you work with and what you can do about that. You may have all of these grandiose ideas, but you're not able to change things because you're beholden to whatever's put in front of you in terms of the technology to deliver care to these patients. And so by building this from the start and from the ground up, this has allowed us to actually be very iterative and create technology that's creating value not only for the patients that we're servicing, but our providers that are actually delivering the services as well. And so when we think about the quadruple aim, and this is a healthcare term, we think about, and this is why we created this company, is number one, we wanted to make sure that we were bending the cost curve. In the US, this is a $4 trillion problem. And a lot of this is due to unnecessary care in facility-based models. The other issue is patient satisfaction. So we wanted to make sure that what we were delivering was an amazing patient experience from the time that they have an acute medical problem to the time that we deliver, that care to them. Number 3 is delivering really great clinical outcomes. By delivering really great clinical outcomes, you can drive, better patient experience. You can also drive decreased costs in care. And then lastly is making sure, and you hear this oftentimes throughout the industry of provider burnout, is how do we make a really great experience and a great platform for our providers to be able to deliver that care. And so those are the premise of why we built this company. And if you go to the next slide, this digs into that a little bit, further. So, and we'll really focus on how we've gotten there. So from a $4 trillion, healthcare problem, each visit on average is around $1,200 of what we save. And so when you multiply that out to the thousands and, over 200,000 patients that we've treated, over the last 5 years, that becomes a pretty big number, relative to solving that problem. As we've added more clinical service lines, which we'll get into, that cost savings has only increased. And so when you think about a patient that we could actually hospitalize inside the home, the savings around that get multiplied for that clinical service. The patient experience, we've had hundreds of thousands of reviews. And the way that we actually measure patient experience is through a Net Promoter Score. And so our Net Promoter Score of 95 is really unheard of in the healthcare industry. Typically, healthcare industry, whether it be health systems or health insurance companies, average around that 15 to 30 for a Net Promoter Score. And then in the clinical outcomes, we've had amazing clinical outcomes over hundreds of thousands of patients of keeping them safely inside the home, making sure that seniors that we're treating are able to age in place effectively in their home and stay in their home by us actually reaching out to them to be able to deliver that care. If you go to the next slide, and I'll give you a little bit of the creation around this. We started really with the pre-hospital and being able to deliver ER level of care inside the home in 2013. To start, that was with a partnership with an EMS agency where we identified patients through the 911 system that had a low acuity 911 complaint that we actually sent out to team to be able to treat those folks inside the 911 system. That expanded to now for patients to be able to access us directly. And that individual could contact us by phone themselves. That could have that patient use our mobile app or website. That could be that patient's primary care physician contacting us through our portal, physician portal, or through the phone themselves, where we risk stratify that individual, determine are we the right size of care, send out the medical team to be able to take care of them inside the home, and be able to avoid that trip to the emergency department. And that in 2015 is when we first raised our first round of capital and built out the platform to be able to support this level of care. In 2017, we were asked by health system partners as we continued to expand outside of the state of Colorado to help them identify patients that they deemed as high risk for readmissions back to the hospital, for intervening on those patients and bridge them back to their primary care physician. So this is something that now operates across the country with many, many health system and payer partners. One of them being actually Renown. They're in the Reno market, and we're doing more and more, of that. The advanced care and extended care model, we spent 2018 and 2019 building this. So this is actually identifying patients that we could admit inside the home for typical medical conditions that you would find inside of a hospital, like congestive heart failure or COPD or complicated UTIs or pneumonia, where we could actually send a team in, admit them to the home setting, manage them inside the home over the course of 2 to 5 days, and prevent a true hospitalization altogether. And so this was really born because of the ER model that we were able to scale over the years. If you think about the data, 6 to 8% of patients that we treat inside of the home need a higher level of care. 75% of that 6 to 8% actually get admitted to the hospital looking at retrospective data. And so we said to ourselves, if we had the right platform and the right technology, we could actually deliver a hospital level of care and really be identifying those patients ourselves. And that patient who had an acute exacerbation of CHF or shortness of breath that we ultimately diagnosed with an acute exacerbation of CHF could be treated by our ER team and then admitted to the home setting without stepping foot in a facility at all. And then lastly is our skilled nursing facility model, where patients that are in a hospital could go home and skilled nursing facility care level that we could manage that patient, inside of the home and avoid a skilled nursing facility. So this was all built out pre-COVID. And then, obviously COVID, hit in early 2020. We decided to and created this partnership with Renown, stood up a new market right during the heat of and the height of a pandemic, and created another business opportunity for us to be able to extend the reach of primary care physicians as well as specialists through the means of a service line that we're calling Clinic Without Walls. So this is individuals that would be treated by their primary care physician, historically in person, that then translated that patient being seen through virtual means. But when you have a patient that's, let's say, 80 years old, has 5 different comorbidities, is on 12 medications, there's only so much you can do through a video interaction. And so we now partner with health systems and provider groups to actually send out an individual into the home for scheduled visits and help enable that virtual visit inside the home. And it's using different technology that we'll showcase here in a little bit. Over the years, if you go to the next slide, we've had great success. We are now operating in 29 markets across the country, have seen well over 250,000 patients to date, have saved hundreds of millions of dollars in unnecessary medical spend. We employ all of our clinicians, and now are over 750 clinicians that are on staff at DispatchHealth or employed by DispatchHealth, delivering the care inside the home. Care integration is very important for us relative to the care that we're providing inside the home, and making sure that we're one piece of the puzzle. So making sure that the care that we provide, the care plan that we provide, is in the hands of that patient's primary care physician or after we complete that care. And that's where some tech integrations have occurred with these EMR systems and provider groups to make sure that that is surfaced for them. And then from a payer lens, as well as health systems, we've been able to contract and work with payers across the country. So we have national arrangements with United Healthcare on all lines of business, Humana, Bright Health, and other payers, not only nationally, but regionally and state-based to cover and for us to get reimbursed for the care that we're providing inside the home and deliver value back to those payers and provider partners. In the next slide, we wanted to go through just a little bit of a video, and hopefully this will work out well, just to get a little bit more context of a patient story and what we're actually delivering inside the home. It's always great to hear from the patient themselves that they're actually receiving the care. And so I just wanted to get this to play. It's only a couple minutes, and then we'll move on to how this actually works end to end. No, it's okay. It's fine. So this was an individual that we had treated with our hospital level of care inside the home here in the Denver market. She was a patient that's on chronic oxygen that had an acute exacerbation of her COPD, underlying COPD, and how this really changed her life, how it actually changed her caregiver's life, which is her son, being able to be safely inside the home, versus inside of a facility getting cared for. So we can go on to the next slide.
Can I just pause for just a second, Kevin? There were a couple questions that came in that I thought maybe we could take a quick minute to answer. The first one was, why is a home visit less expensive than an office visit?
A regular office visit for the primary care physician.
Yeah, so the idea being, if we're coming to the home to provide care, what makes the home visit less expensive than someone going to the office?
Yeah, I mean, we are not, and this is actually applicable for this slide that's showing up right now, is that we want to make sure that we're not disrupting the care that you're having or that continuity with your primary care physician. So first and foremost, if you can continue to see that primary care physician, you may have a medical need, be able to be in contact with that primary care physician and schedule a visit with them. We definitely continue and want to promote that. This is, for us, being able to intervene on that patient that they call the primary care physician. That primary care is not comfortable, seeing them in that given day based on schedule constraints, or not comfortable with caring for them over the phone. We are not then flexed in to be able to intervene on that patient inside the home to avoid them actually going out, to the emergency department to seek care. So if anything, your primary care physician is going to be less expensive than actually seeing a service like an ER or, in our case, kind of a mobile ER or urgent services that are coming out to the house. Does that answer the question?
I think it did. Yeah. And then the next question was, are we capable of being able to treat someone who experiences AFib in the home?
Yeah, it really depends on, we do treat individuals underlying AFib. It really depends on the other symptoms that are related to the AFib and what's going on. And so we'll get into our tool that we have to risk stratify patients up front to make sure it's safe to deploy our medical teams inside the home. And that's a great example with that symptom or that condition coming in. We then will present appropriate questions to be able to drill in to say, hey, is this someone that actually has a time-sensitive condition to be able to go out and see? We don't do cardioversions, on AFib at all inside the home. So there is components to this that we'll treat for underlying AFib, but if they are having an arrhythmia that is causing them to need to be cardioverted, that would need to be in the emergency department.
Gotcha. Thank you.
And so just a little bit further information around this. We are not someone that is going to disrupt that continuity with the primary care physician. We're a new tool that those primary care physicians can be leveraging for us, or to be able to apply, to us to be able to intervene on patients. Same thing with specialists, whether it be cardiologists, whether it be orthopedists. We can flex in to be able to intervene on patients that are unable to get into their office and be essentially their eyes as well as their hands to be able to present back to those clinicians. Pharmacies, as well as behavioral health providers or home care services, home health agencies, senior communities, we do a lot of work with, and really just being an option for them to be able to intervene on those patients to keep them out of the right-hand side of the screen in terms of facility-based care. If an individual is in one of those facilities, we also want to make sure that they're transitioning the other way outside of the facility and back into the hands of the primary care physician. And we do that with different protocol development, different clinical as well as technical integrations with the medical team on the left-hand side, as well as the hospital care on the right-hand side. And I think, we're now going to kind of go in, and Joe's going to give a little bit more specific, details of how this would be applied, in Reno, and go through a couple different examples there.
Yep, exactly. Yeah, let me take you on just a little bit more granular deep dive into like how it actually works when we're here in Reno. And like Kevin said, there's a lot of technology that makes this magic happen. And so you see this a little bit, and then we can show you a little bit more behind the curtain. So typically when we go out to see a patient, we think of providing healthcare in a home, which is of course what we do, but there's also a huge, there's like an entire journey that the patient has to go through and that we go through with them, all the way from getting that patient onboarded to providing the care, to communicating back to their healthcare providers, to communicating with the insurance company, to coordinating everything. And if there's a follow-up needed after this, to get that scheduled as well. And there are other kinds of programs where, for example, we might not visit a patient because they have an urgent care need. We might visit a patient because their doctor has requested that we go and see them after they've had a surgery. Maybe you've had a surgery and you're at home trying to recover. You need a little bit of follow-up care and you don't feel like going back into your doctor's office, or your doctor is just booked at the time that they want to be seen. So we provide those services to physicians as well. When we do go out to patients' homes, just to give you an idea of who we send, we always send someone who's trained at a nurse practitioner or physician assistant level. So that means this is someone who can administer care, can write orders, can write prescriptions, and can administer treatment. That's always one person that we send. There's always someone who goes with that person who is a medical technician. So think of them as like an EMT level of training. They know everything that's going on with the equipment. They know how to get things set up. They know how to keep things moving throughout that patient experience. And if they're on the scene in a patient's home and they ever need to consult with a doctor, if they have a question, they see something that they're not expecting on the initial phone call, et cetera, they always have a board certified ER doctor there on the phone available to them if they ever need a consultation. This kind of shows you just some of the equipment that we bring to our patient visits. And we pack 7 of these kits into those cars that I showed you a couple of slides ago. You can see here the different types of kits that we take out. We do have all of the kits in the cars when we come to a patient's home. However, as Kevin will show you in the risk stratification, we kind of already know what we're going to need to actually bring into the home because we've already communicated with the patient or with our care team. So although we bring all of these, and you can see all of the different types of treatment and kits that we have there, we may only take 1 or 2 of these into a patient's home because we kind of already know what we're going to expect when we get in there. This also shows you some of the diagnostic tools that we have available. We can test in patients' homes for flu, strep, COVID, and all of these other tests that you see here. Some of them, like COVID right now, we have to send out for. There are some other tests that we collect the specimens and then we come back and we do the test through Renown Labs. And then we also have mobile imaging partners, because sometimes there are people who need x-rays or ultrasounds, and that equipment is pretty big and bulky. So we don't carry that equipment with us, but we do have partners available that we can write those orders and get mobile imaging services out to patient homes when they need them. If you're thinking about, where in the area we service, because we have a really big community around here, you can see here our service map. And if you ever have a question or just want to know if we service your area, you don't need to memorize the zip codes. We're not going to quiz you on this at the end of the presentation. All you have to do is go to our website, and right there on the home screen, you'll see a box that you can type in your zip code, and it will tell you right there, yes or no, we can come and you're in our service area. As you can see here, we monitor all these zip codes. There's about 25 that we're currently serving. We monitor the outlying zip codes, and we do go out occasionally to the outlying areas. We get quite a few calls from Cold Springs, and so we'll venture out there every once in a while. And as we monitor the zip codes and as we see demand occurring, we'll turn those zip codes on and expand the service area. We're also anxious to be able to expand, hopefully in the near future, into Carson City, because we do get quite a few requests down there. And then I had to share a fun story with you as you look at this service area. I'm going to move everyone's window over here, but you can see we kind of go pretty far out to the south and to the west down there, kind of in the Verdi area and that area. And as you know, that can be kind of a mountainous forested area. And it was last fall. One of our teams went out to one of these locations in a patient's home, and they called into our call center and they said, we can't get to this patient. And the call center said, what do you mean you can't get to the patient? Did we give you the wrong address? Did the road wash out? Did something happen? What went wrong? And they said, well, the reason we can't get to see this patient is because of bears. And this was a family who apparently was new to our area and didn't realize that you can't just leave your trash cans out in your driveway if you live in certain areas of our community, because you kind of get unwanted visitors. So they were kind of stuck here. And of course, our call center had expert advice for them. They said, hey, we want to see the bears. So they started taking pictures and sent them into our call center. The outcome was that they were finally able to get a hold of the patient's family. The family was able to come out and shoo the bears away, which I wish I had photos or video to show you, because that would have been fantastic. But they were able to shoo the bears away, and they did get in to see that patient. So even bears can't keep us away, although we might be a little bit more extra careful around them. So Kevin, I'll turn it back over to you, and we can get into some advanced care information.
Yeah, so it's a good transition if you go to the next slide there.
Okay.
So if you can imagine the patient that Joe just walked through, and maybe not the bear patient, but another patient that we were treating that needed higher level of care. So we went out and we assessed them. We may have worked them up with the lab capability that we have. And it was determined that it would be best that they spend some time inside the hospital. This is the patient that we would then flex in, if available in a given market, our advanced care or internal medicine hospitalist team. So what would happen is we will go through a clinical assessment, social assessment, determine, is this home set up for success? Is this patient set up for success for us to transition that care from our ER model to our hospital model and take over that care. And so the individuals that would be out inside the home would be that NPPA ER trained provider along with a DHMT. They would then get in contact with our advanced care team to be able to admit them if clinically appropriate and if the home was set up for success, meaning is it safe to be able to provide this care. And we have those assessments built into our technology to make sure that that we are set up for success. That patient would be managed by that advanced care team over the course of 1 to 4 days inside of the home, and then we transition them for another 30 days to be able to prevent further reduce readmissions. All the things that you would expect inside the hospital, like bedside nursing, like 24/7 support or a call button, making sure that there's meals available, making sure that there's physical therapy, occupational therapy, making sure they have imaging coming to the home, making sure they have all their prescriptions delivered, durable medical equipment. All of that is actually brought in, and that home is transformed into essentially a hospital room for us to be able to manage that patient. The nice thing about this is that patient is still able to walk around their own home. If they want to, they can cook their own meals, and they're comfortable in that setting versus the typical setting that we're all used to inside the hospital. All of these patients have remote patient monitoring. They have call buttons, and then availability with our other acute care teams available to flex in if there's a need. So there's 3 different ways that we do work with for this service line to be identifying patients. Right now, if you're following CMS, Centers for Medicare and Medicaid, out of Washington, they have a waiver right now because of the pandemic to allow for Medicare to reimburse for the service with health systems. And so we're actually working with a health system up in Tacoma, Washington, to identify these patients. We then will flex in our team. They get identified in the ER, like number 1 up there, and we'll manage those patients and transport them back into the home for us to take care of them versus them going upstairs to be managed inside the hospital. And lastly, primary care physicians, about 25% of the time, identify patients that we could directly admit them, into the home versus them directly admitting inside of the hospital. Next slide. These are all just a little bit further detail of all the different services that we provide, from clinical service, daily rounding, bedside nursing, medications, remote patient monitoring, all the different social services that would be needed, to take care of that patient safely inside the home. We coordinate all the care. We build the network. So when we work with payers on this, we'll build that top tier network of to manage that patient effectively. So working with imaging companies, working with respiratory therapy, working with PTOT services to come in and really subcontract out those services to be able to effectively together take care of that patient, inside the home. Next slide. And we've had, tremendous results. From a social perspective and being, available to be able to optimize, medications, to be able to intervene on, social, gaps inside the home. All of these things we've been able to achieve with dramatic, clinical results with this hospital level of care inside the home, built on the dramatic, success that we've had with our ER model inside the home. We just announced the first ever national contract with Humana a couple weeks ago, or was it last week? Maybe 2 weeks ago, which is the first in the industry to have a national contract with a Medicare Advantage plan to be able to deliver this level of service inside the home. Next slide. Now, how does this all work, and how's the technology really fit into this? One thing that we learned early on, and if you go to the next slide, is that we needed to do a lot of different whiteboarding and mapping all out, or mapping all of this out to make sure that we start to identify the needs of our patients, the needs of our partners, and the needs of our providers to effectively take care of these patients, inside the home. And so this has been a journey since 2015, bringing over our first set of software developers to now having a team of 30, I believe, software developers, all located here in the Denver area, with a robust data science team, product management team, the platform to help enable those different clinical service lines that I mentioned early on. Where it starts is really with the risk stratification. And so if you go to the next slide, this is kind of a picture of some of the components with our platform. But going to the risk stratification slide, this is really the front door to our service. And so when we onboard these patients, we want to make sure that the patients are safe, making sure that our providers are safe, and making sure that from an experience standpoint that we're delivering a service that is covered, a covered service, we're a covered entity from a provider organization for that patient. So making sure that those patients aren't going to get stuck with a bill that's out of network. We want to make sure that we identify that right up front. And so from a clinical standpoint, we built out a proprietary risk stratification tool based on individuals' age, based on their gender, based on their chief complaints. We will then identify specific questions using natural language processing from the chief complaint to determine, all right, what other questions that we need to be surfacing to rule out time-sensitive problems with that patient that would lead that individual to need higher level of care. And so the output of this is essentially a stoplight of green, yellow, red. The green being, hey, this patient is clinically safe for us to assign a medical team. When we have the individual in the yellow bucket, our technology will surface those available providers that are out in the field based on their licenses in their respective markets and where the patients are to surface, as well as their status, meaning are they actually in front of the patient? We don't want to disrupt that care, but is a patient or is one of our providers in transit from one patient to another and they're available to take calls? We will then directly get them in touch with the patient to be able to further screen that individual. And so when we screen that individual, we will then push down to make sure that it's safe from a green perspective for us to go see, or we need to actually push them to a higher level of care like the emergency department. And so this is super important for us, as we move forward to further right-size care for that individual. And what we've done over this last year is actually take this a step further to say, hey, maybe not everyone needs our ER team, inside the home. And is there another way that we could actually, based on the risk stratification, identify patients that we could send out a lower level clinician to be able to present back to our providers, and those providers being centrally located virtually to manage that patient. And so we call this telepresentation. And if you go to the next slide, this is starting to take the risk stratification tool and providing further sophistication to say, hey, the individual, based on their age, based on their complaints, we will determine, is this something that we could actually take care of by sending a single medic out into the home, and this is live in a few different markets right now, to be able to present back to one of our clinicians. And so what's the equipment that medic is actually supplied with gives the ability to be able to perform real-time examinations. And so if you go to the next slide, this will highlight the platform that we have. And so what you'll see is, and I have one right in front of my desk here to give you some context in terms of the size. This is the size of the device. I'm not a big guy, so my hands are very small, and so fits in the palm of your hand. And what this does is actually enables different peripherals to be attached to it. And so it has a high definition camera attached to it from a skin or dermatological exam, and to take pictures with a high definition camera. It also has a temperature gauge to be able to perform and understand your temperature from this device. And then it actually has peripherals that you attach to it, and it turns it into a stethoscope. And so as a medic, I will be on scene with that patient to be able to put it on the individual's body and transmit real time those heart and lung sounds back to one of our clinicians to make clinical decisions on. Another common use case is the 5-year-old or 2-year-old that has ear pain that oftentimes are used with virtual meetings, and it could be a teledoc service or a MD Live service or many other virtual services that are out there. And the symptoms are my child has ear pain and he's tugging or she's tugging on her ear, but what's really going on in that ear? And so you actually treat them without ever looking inside of the ear. So you're making a treatment plan based on symptoms. So what this does is it allows you to actually stick a stethoscope at the end of it stick into the ear and get a picture of the actual tympanic membrane real time to determine, do they have an active infection going on or not? And so it really enhances those visits. And this is really for a number of different applications. We're using this in our Clinic Without Walls model to be able to present back to our partner primary care physicians and specialists. And it has a lot of great applications when you mirror the clinical decision-making and that real-time exam, along with doing point-of-care lab testing, being in the home to be able to do social determinants of health assessments, and to be able to act, on those patients in a more meaningful way. Next slide. This is really getting into, and I wanted to dig into our logistics, platform. So this is something that we've built from the ground up. We now have, I think, in our fleet that's operating every day about, I want to say 150 vehicles across the country every day within those 29 markets. Just in Denver, and this is actually a geo map of Denver, we have 20 vehicles that operate every day. That's in comparison to the Reno market, that's two vehicles. That will expand as that continues to mature. But 20 vehicles servicing patients from 7 a.m. to 10 p.m. You can imagine that we want to optimize those providers in terms of who they're going to see and being able to geofence those patients to be as efficient as possible. And so with the help of our data scientists that are focused on this logistics problem, we built out a simulation environment to help be more iterative on solving business problems. And so based on clinical acuity, service level agreements, we can then make adjustments to our logistics algorithm and see the impact that has actually on the performance of the logistics model. And so this is just an example of us applying some of our logic and what the impact really has on a given day by evaluating a pre versus post implementation of part of this. So Joe can run you through that. Luckily, there's no sound to this, but what it's really showing is the routes of different patients and how we can be very quickly iterative around building out and optimizing our logistics platform. So anyone in the logistics business, and there's many different platforms out there, none that are really solving the healthcare problem. And so, and none are really solving problems relative to our need from an on-demand perspective. And so if you think about in a given day, a logistics problem is actually pretty easy. If I'm going to see 15 patients and they're all located here, and I can optimize routes based on that. But when you have a dynamic day where we have no idea who we're going to be seeing tomorrow, and where those vehicles actually need to go, there's a component of using historical retrospective data to also making sure that from a clinical acuity standpoint that we're serving these patients safely. So this is an area that we're spending a ton of time from a software development standpoint to make our vehicles as efficient as possible. Now, the other thing to consider is, and where we're at today in a market like Denver, is that in a market, you're going to have vehicles that are operating with certain levels of clinical capabilities. Then our ER model, then we also have our advanced care teams. And so that logistics platform is not only solving the on-demand, but it's also solving what's the best path for a patient census for us to manage and do daily rounds on these patients inside the home. So it's things that we like to geek out about. We love this type of business problems and being able to tweak technology platforms to be able to push this business forward. Next slide is, can't remember. Is our social determinants of health. And so just a little bit, you may have heard the buzzword about ESTO or social terms of health. This is a real problem. And as clinicians, back in 2013, seeing patients, for years and years and years in my office setting or in the hospital or seeing them in the ER, you really don't have a great insight as to some of the other social components that are impacting one's health. And so when we started the company and we started seeing these patients inside the home, we were very comfortable treating their acute medical problem. But when we were out there inside their home, we were also seeing, and they were also very transparent as to what else is going on, with them. And so how to identify patients that may be a fall risk. I may not see that when I'm in the office setting, or the patient may not be foretelling me that they are having challenges getting around their home. Or, hey, do they actually have food in the fridge? And so you go over to the fridge and actually take a look at it. Are they a newly diagnosed diabetic or a CHF patient, and they got a bag of Doritos, right on their counter, along with their medications everywhere? And so we have great insight as to what's going on with them medically, but also socially. And so over 2020, we saw probably these patients that we saw in the home, nearly 200,000 data points just in the 2020 relative to social gaps and the need for social resources. We've had we continue to this is a very, very difficult problem, but it starts with the data and making sure that the data is structured to be able to start to act on. And we started to develop further partnerships during the pandemic. We started, and you see one of the photos here, equipping our vehicles with bags of food that we could actually leave behind for patients if they did have known food insecurity issues. We've built our software platform to be able to support this. And so if you go to the next slide, this will go through an experience. And on our back end, we use an electronic medical record system. EMRs are really not built out, and we use a very common one called Renown Health to be able to support a social terms of health assessment. And not only in an assessment, but how do you start to trigger what resources are available for that patient based on their insurance benefits or based on resources in that community. And so within our iPad app, which we call our Rover app for our providers, we have the ability to do this assessment and then based on that assessment, surface up available resources within then that community to be able to supply to our providers. Next slide. The next thing is really, and how much time do we have? I just want to be clear.
We could go on all day, huh?
Yeah.
You have 10 or 15 more minutes.
Okay. So this should be perfect. Only a few more slides. So this is, if you think about our risk assessments for the acute business and making sure that we're right-sizing them, I also talked about the social as well as clinical assessments that are needed for our advanced care team. So this is specific to the home. There's nothing out there that's available. And this is another patent pending technology that we have around identifying the right level of care relating to a hospital level of care. So we go through this assessments clinically and to make sure they meet admission criteria. But what's fed into that, which is important, is not only clinical data, and that's kind of the easy part, but are they actually going to be set up for success? And so we go through different assessments that are built into that workflow for our hospital team there. The next slide kind of goes a little bit deeper into that, which guides kind of that admission process. Once those patients are admitted into the next slide, you'll see, and we talked about remote patient monitoring, having a PERS device available for those patients from a call button perspective. We have 24/7 oversight, on these patients. This is our platform to be able to manage this remote patient monitoring. And remote patient monitoring comes in a lot of different flavors, a lot of different companies out there, a lot of great innovation that's occurring with remote patient monitoring. The service that we have implemented right now is actually I'll call it more of a engagement platform to engage the actual patients in their health by actually making them go through this process of putting the pulse ox, on, or getting a blood pressure, reading, stepping on the scale. And we guide them, through that based on their care pathways. There's also other technology that's out there, and actually spent last week wearing a patch. And so this patch is a really passive way to monitor some of this data. You wear the patch; it looks like a big Band-Aid, on your skin, and this constantly collects data, just like your watch or your Fitbit. This is a little bit more comprehensive on what's happening with that patient, and so you can kind of start seeing trends relative to activity, or relative to vital signs that we're collecting to be able to intervene on that patient. And so the technology and the hardware and the software that's being transmitted, the data that's being transmitted via the software, is really not where the innovation is. The innovation moving forward with that technology is when to respond to that data. What data is real that I need to pay attention to? What data is just going to be, complicate things or make it even further, gray in terms of the story? And how do you make it smarter to know and be more predictive as to when I need to intervene, with the right resource on these patients? And so there's going to be a lot of work, throughout the industry, on this moving forward, because remote patient monitoring is a place where we'll continue to see more and more of it to effectively take care of patients virtually, as well as, in person, inside the home. The last piece of technology that I wanted to show you, and Joe kind of talked about ultrasounds and x-rays being very bulky, and we're not able to deliver, those services. There's a lot of advancements that are occurring with ultrasound right now, and even x-ray. And so x-ray, we do have those services that come into the home, and about 20% of our patients require some level of imaging study. There's also a lot of advancements on the ultrasound and being able to do ultrasound at the point of care. And so this is the company that we've partnered with called Butterfly. And, this is kind of looks like a device that I just, shaved my head with, but it's actually a mobile, ultrasound. And so this is, in my view, one of the coolest technologies that's out there right now, is having the flexibility and using this really as a clinician as my new stethoscope. And so just like a stethoscope I wear from patient to patient, and I put it on and I listen to their heart, lungs, and their abdomen, this is a device that's now being used and really democratizing ultrasound. And so more and more providers are really, have a holster right on their belt buckle, and using this to evaluate patients. And so right now, with our advanced care patients, we are equipping our clinicians with mobile ultrasound to be able to have quicker diagnosis and quicker evaluations, for these patients by controlling different settings to evaluate their lungs, their tissue, musculoskeletal, problems, being able to insert, tough IVs, using ultrasound. So very, very, very cool. And I think you're going to probably see and hear much more, from the point of care ultrasound. There's a lot of different companies doing this. Is just one, Butterfly, but just wanted to showcase that as well. And then lastly is just the ability to equip our advanced care team. So this is really essentially a task list. As we have patients on service, we want to make sure that if there's 10 patients that we're managing on an inpatient service inside the home, we need to identify what services are needed for that patient based on their episode of care, and what we need to intervene and who needs to intervene. And so this is really more of a logistical problem, supply chain problem. And so it's coordinating to make sure if I'm going to go out, we're going to go out and see that patient today, what are other services that we're going to need to be able to control from a supply chain management perspective that we may own or we partner with. We want to make sure that we're the quarterback in coordinating all of that. And our technology is coordinating who needs to be where for a given patient in a given day. And that is it. So that's what we're up to. You know, we're continuing to grow. We should be seeing this year alone in 2021 nearly 350,000 patients throughout the country. We'll continue to expand to more and more markets and continue to have more access to the service in the state of Nevada, in particular in Renown, with the partnership with Renown.
Thanks, Kevin. That's everyone, as you can see, that is an amazing amount of technology. Only a portion of that we're currently using right now in our local markets, but we will, continue to keep rolling those things out, and we'll have new announcements on new treatments and everything as we continue to expand. So thanks so much for your time. Tori, do we have any more questions in the chat?
Oh my gosh, I've been busy the whole time. You guys have been great with questions.
Fantastic.
I just been trying to fire some responses back so that everybody can just kind of keep listening. But if there was anybody that I didn't have a chance to respond to, feel free to unmute and ask your question. And if there aren't any questions, we had a volunteer who was willing to share a testimonial.
Terrific. I love that too.
Real quickly, Tori, I'm on my chart with Renown. Are you guys involved with that? So if you had a visit here, I'd be able to get updates as to what happened and, test results, et cetera, on my chart.
Go ahead.
Exactly. As a matter of fact, a lot of our patients who get tested, like for COVID, let's say, right? Sometimes my chart will post their test results before we can even get back to them. So yeah, since we're partnered with Renown, those things come straight through to my chart very quickly. Yeah.
Thank you.
Good question. And then we had a volunteer who was willing to share a testimonial. So if you would like to unmute yourself, Veronica.
Sure, I'm happy to do it. And I owe this to Tammy, who happens to be one of my best friends. And so, she's married to Joe. And I had the opportunity to use Dispatch last November. And Tammy had given me the flyer a couple months before, and I had put it away and I didn't really think twice about it. But I had my first ever bout of what I learned later was vertigo. I was doing some yoga in the morning and I went into the full spin and I got worse progressively throughout the day. And my blood pressure started going up higher. And I was worrying about that more than anything else. I didn't know what was going on. And so my husband, when he saw my blood pressure scores, he said, we're going to the ER at about 8 o'clock at night. I made it about as far as the driveway in the car. And I burst into tears because I'm like, I don't want to go to the hospital right now. I mean, who wants to go to the hospital right now? And at that moment, and I think, Tammy, you must have been sending me your love as you always do. And I just remembered the flyer and went back in the house and called Dispatch. They did the risk assessment. They were at my house on the Virginia foothills off a dirt road. 75 minutes later at 9:30 at night, they even had an EKG to rule out anything serious, which once they did that, my blood pressure went back down, which was amazing, back to normal. They explained what I had, that I had this BPPV vertigo, and they gave me the exercises and all of that. And they were so kind and so professional and so thorough and just so patient, took the time, even though it was 9:30 at night. They billed my insurance company. I paid $40, which is my copay, my urgent care copay, which just floored me that it wasn't any more than that. And the best part was that I felt safe at home, the comfort of my home, and I had the best care, the only care I needed, saved me money, saved the system money. It was just an incredible experience. So I'm glad I have the opportunity to share that. Since we couldn't hear the film, I offered to Tori to share mine. So that's why I volunteered.
And that's even better than the video.
Right?
That's fantastic, Veronica. Thank you.
Yeah, thanks for sharing.
Thank you.
Thanks for sharing.
So I have a question. With your services for an employer insurance group, would you all file the claims to the employer's insurance? Or does the employee have to file the claim? How does that work?
So on our end-to-end solution on the back end, we have what we call our revenue cycle management group that will actually, based on the charts, the charting that our clinicians will do, they will then submit the appropriate claim to that respective insurance that is covering that patient. And so just like Veronica, had, her, claim submitted to her insurance, that individual, whoever they're employed by, it is covered by whatever insurance that we're contracted with. That's our claim that we'll submit to that insurance.
And what does this fall under? Does it fall under like an urgent, I heard Veronica say an urgent care cost. Is that what copay it would fall under potentially?
Yeah, so the majority of those will hit your urgent care benefits on the back end to copay. Obviously, that will be different for every patient depending on their plan and their plan design, but yes, it will hit their urgent care benefits.
And how do I get information to share share your plan with my employees?
That's
Best way to do that is just make sure that Tori has your email or put it in the chat, and she'll grab it, and Tori and I will reach out to you and get you everything that you need.
Thank you very much.
You bet.
great
Thank
question,
you.
Dee Dee. Thank you.
Yeah, thank you.
I had my own in-home service to myself. Actually, last weekend, I decided to crack my head open at the same time at 8:30 at night, and I had my scalp sutured up, inside the home. And again, I mean, this is something that I couldn't get to stop myself. And I didn't actually come out. I had my wife actually just sew it up, inside of my home. But it's a great, example that this is something that you flex in, avoid the trip to the ER. I looked at myself, as I saved I have a very high deductible plan, a $500 copay, and treated right inside the home. I didn't have to go anywhere.
I have one last question, forgot. Do you all have providers that will help those that English is their second language?
So we have translation services that we leverage. And so based on the need, we will then power the translation service up during that visit. And so the individual essentially will be be part of that visit to be able to help translate our providers, exam, and evaluation with that patient.
Well, I want to thank Joe, Kevin, and Tori. You guys were wonderful and incredible amount of information. Thank you so much for coming to us today and sharing all of that.
Oh, thank you, Dave, for allowing us to come and share time with everyone. And thank you, everyone, for your time and attention. And like we said, make sure that if you want more information, you want to follow up for your company or for yourselves, leave all your information in the chat, and we'll make sure to get back to you.